You guys ready? Okay. Thank you for coming. Yeah, this is like, clearly they saved the best for last.
I know Friday afternoon's hard, but we really appreciate
We
you
do
being
appreciate,
here.
we appreciate you being here. My name's Aisha Khan. I am the Social EM Director at Stanford.
And my name's Sachita Shah. I'm the Fellowship Director for Global and Rural Health at University of Washington.
Do you want to move the mic closer? I don't think it's picking up your voice.
Hey everyone, I'm Sally Mahmood Worthman, and I am the Social EM Fellow at Stanford.
Awesome. So we've been doing this talk for a few years now. It's usually the top 10 papers, but we got 20 minutes this time. So we're going to do the top 5 papers. We're going to do it as fast as we can. Just a word about our methods. So we generally have gotten this down to doing this in the same way every year. And what we do is we review PubMed and Google Scholar for any of those topics. We look at what we feel are the most pertinent articles. This time we reviewed 64 articles. We ranked 9 of them, and then we finalized 5 from those 9 after a discussion. The first of which was understanding the association between frequent emergency department use and incarceration. This was a cross-sectional analysis. The reason for this paper was actually really interesting. I'm sorry, is there a bit of an echo?
A little bit.
Is this better? Better? Better, okay. So the hypothesis was there's an association between frequent ED use and incarceration, which I think is often called the revolving door, just hasn't really been actually proven. The thought behind this is that ED visits are a sign of increasing social instability, behavioral health problems, and addiction. And the objective was to find this association, characterize the population, and identify predictors to inform the intervention. The idea being that if we can address this population's needs, we can prevent future incarceration as well as reduce excess mortality. This was a retrospective study. It was a cross-sectional analysis of the San Francisco Department of Public Health Coordinated Care Management System over 1 year, mid-2018 to mid-2019. So this SFPDH-CCMS is a system in San Francisco which actually records every individual's, makes a chart for every individual who has ever accessed housing services, behavioral health services, jail health services, or any San Francisco housing itself. And then also it records urgent or emergency care visits, mental health care visits, substance use services. So it's a pretty extensive repository of exactly the things that we need to be looking at. For the medical services, in California, the Medicaid system is tied to the county. So for San Francisco County Health Plan, all of the visits of patients that had that were recorded, but people who did not have that particular health plan, only the visits to the sites that are run by the San Francisco Department of Public Health were recorded. So we did miss a few. Included all people who were 18 and excluded people with greater than 200 visits to the emergency department or psychiatric visits to the emergency department. The reason being that they believe those were outliers. The primary outcome that they looked at was jail encounters. The primary exposure was frequent visits to the emergency department. And then they also looked at some covariates in order to characterize the demographic population. There was a total of 46,752 encounters that they looked at. They did a bivariate and multivariate logistic regression in order to look at the associated variables. And in addition to that, they wanted to look at the temporality of the ED visit. So they looked at this 30 days before jail and 30 days after jail. They excluded the day that the person actually ended up going to jail, as well as any health visits while the person was in jail. Of note, in the covariates, they chose to include race, because race they were looking at as a proxy model, not to imply a biological explanation, but rather as a proxy of the structural systemic racism and acknowledgement of the policies that have led to the mass incarceration of Black people in the United States. That was very nicely, I thought, stated in the article. And being that their goal is eventually to look at structural changes that they can make, I thought that it was a very valid argument. The population within that 46,000 or so that had actually had a jail visit was 3,713. They looked at their ED use and found that people who had no visits to the ED were 4%. Those with infrequent visits, being 1 to 3, were 17%. Frequent visits between 4 and 17 visits a year were 34%. And then 17%. And then super frequent ED visits were 34%. The most important finding out of this was the odds ratio for super frequent ED visits ending up with at least one jail visit. And that odds ratio was actually 12 when unadjusted, which is huge. But then when they adjusted for all of the other covariates, they found that it was 2.6, which is still quite a large odds ratio. Additionally, in the temporal analysis, they found that 1 out of 5 of the patients with jail encounters had a visit to the ED within 1 month prior to going to jail. They also looked at those experiencing homelessness and substance use and noticed that the trend persisted, that there was a higher proportion of those who were incarcerated amongst the population that were unhoused and had substance use disorder. And then additionally, of those who were experiencing homelessness and had substance use disorder, as well as were jailed, the trend for super frequent ED visit use being a predictor continued. So the key points here are that ED visits and jail encounters are associated, and additionally, there's a temporal relationship. So this makes the emergency department a fertile place for both behavioral health interventions as well as housing interventions that could prevent incarceration.
Okay.
All right, everyone. Okay, so I'm just going to be a little closer to my slides here. Okay, so this first presentation describes a program that was trying to get providers to use buprenorphine more in the emergency department. And so they described the program and all the different components to it, and then looked at how providers used buprenorphine afterwards, before and after. So we all know that there's a lot of evidence for using bup in the emergency department, right? It improves patient mortality, improves their mental and physical health. It's also associated with increased treatment engagement after they leave the emergency department. So starting patients on bup when they're in the ED is an excellent opportunity to intervene and to seize. Less is known on how to implement some of these effective programs in the emergency department. So this study was a multi-pronged effort in improving buprenorphine prescribing. So the program had multiple different components to it. And so at that time, the X waiver was more relevant than it is today. So they had financial incentives to providers so that they can complete their X waiver. In addition to that, they also had peer recovery specialists. So these are similar to substance use navigators as well. And in this hospital, they actually had peer recovery specialists that already existed in other parts of the hospital, but not in the ED. So they brought them downstairs to the ED. Additionally, they developed these clinical decision support tools in Epic that helped providers and eased the prescribing practices for providers. So for example, they developed an order set for patients when they're discharged. So they also did some provider trainings, and they reinforced positive behaviors and positive change. So closing the loop with providers when they're starting a patient on bup who hasn't relapsed. Providing that closure and that positive reinforcement was huge as well. So the question that they asked was, what is the impact of this multi-component strategy in improving the use of BUP on treatment and process outcomes for patients with opiate use disorder in the ED setting? What are those treatment and process outcomes? Treatment outcome number 1, BUP treatment rate. Proportion of patients receiving methadone in the ED, proportion of patients receiving naloxone prescriptions at discharge. Provider level prescribing of BUP. And then the process outcomes focused on looking at withdrawal, so using the COWS scale that we're all familiar with, and also using the order sets that were developed. So this was a retrospective chart review. So they looked back at all of these charts for patients who were over the age of 18 years old and presented to the emergency department with an opiate use disorder related encounter. And they looked at a bunch of different variables, right? They wanted to know, what did that visit look like? Did they come in after an overdose? Did they come in withdrawal? Did they come in for foot pain? What was it that it was in their chief complaint? And then they looked at demographics, so things like age, race, ethnicity, sex, comorbid mental health and substance use disorders, ED length of stay, which is important to look at, especially considering boarding right now is a public health crisis. So we want to make sure that interventions aren't increasing length of stay significantly. Repeat ED visits, so patients coming back to the emergency department within 30 days after discharge, and also hospital admissions within 30 days. So they used descriptive statistics to describe the sample population, pre and post program implementation, to make sure that the study sample didn't look very different before they started the program compared to after. They also did a provider level analysis of the rate of BUP prescriptions per OUD related encounter. And they did an interrupted time series analysis using logistic regression to get an understanding of the associations of these ED interventions with BUP use and other outcomes. And this is important in comparing the time period before the program was implemented and after. So the study sample had about 2,600 OUD-related encounters, and there was pretty split even between before and after the program's implementation. Mostly they were middle-aged, male, publicly insured, 55% white and about 40% black, low comorbid mental health use disorders. Also, patient characteristics, generally speaking, didn't really differ before and after the program, which is good. 28% of the patients came in after an overdose event, 8% came in with withdrawal, and 64% came in with something else. They collected urine in some of the samples, not all of them, but about 30% of the time they did collect urine samples. And then again, they looked at these factors, which they found did not significantly change pre and post program. So length of stay, 30-day ED visits, and hospital admissions did not change significantly after they implemented this program. So overall, 13% of patients received medication-assisted treatment during or after their ED visit. 3% of patients pre-program implementation, and post-program implementation, 23%. So that's a net increase in 20%, which was statistically significant when looking at the p-values and confidence intervals. The majority of the patients received BUP rather than methadone, and they received it either in the ED, at discharge, or both. And there was no significant change seen when looking at methadone specifically, which makes sense because they didn't really target methadone when they were doing this. So the order sets were more about BUP, for example, in the provider trainings. So in looking at the results, there was also increases in naloxone prescriptions at discharge. However, there was a steady increase even starting from the program to the end of the program, so that wasn't associated with the program's implementation. There was increase in all process measures after the program implementation. So the order sets, the COWS measurements increased, And among doctors who had 10 plus opiate use disorder related encounters, pre-program, 7% of them wrote any prescriptions for bupe, and post-program, 70% of them wrote at least one bupe prescription. So this table basically summarizes some of the stuff that we talked about already, and highlighting that after this program, there was a statistically significant increase in bupe treatment rates. And this is just a table that shows when the program was implemented, you can see that the bupe administration in the ED, for example, increased. Naloxone prescription at discharge overall increased as well. So the take home here is that with a persistent effort that has multiple different components, it is possible to statistically significant increase bupe use in the emergency department and provide first-line evidence-based treatment for patients with opiate use disorder without increasing length of stay. This next paper looks at how race, as well as some other variables, relate to ED boarding. So ED boarding, as I mentioned previously, is a huge problem. We all know that, right? It's a critical indicator of patient-centered outcomes. As boarding times increase in the ED, things like mortality increase in a linear fashion. Prior studies done over 10 years ago did show that there might be an association between Black patients boarding significantly longer than other patients in the emergency department. So this was in 2 hospital emergency departments at University of Alabama, where they had approximately 70,000 annual ED visits. And the question that they asked was, are there disparities when it comes to looking at ED boarders across various demographic groups? So again, here they did a retrospective chart review. They went back and looked at all the ED admissions at this hospital between April and September of 2019. And the primary outcome was boarding time. So the time that the provider marks the patient as ready for admission and the time that they actually leave the department. And they looked at this demographic data and also the visit type. Was it a medical admission or was it a psych admission? The study sample was about 17,600 patients. The mean age was about 56 years old, about 50-50 male and female, 44% Black, 48% white, and the majority of patients were ESI 2 or 3. The most significant findings here are that when looking at patients who are ESI level 1, right, so the patients that need the most resources the quickest, Black patients boarded longer than white patients, and this was significant looking at the p-values. Black patients also boarded significantly longer than white patients when looking at psychiatric admissions. Among all admissions, males boarded longer than females. In general, in this study, women were a little bit older than men, so that could potentially explain that. And patients older than 75 boarded for less time compared to the younger groups. So this table here just highlights that again, that among ESI 1 patients, Black patients boarded longer than white patients. Black psych patients also boarded longer. So the take home here is that boarding times do vary depending on what demographic group our patients belong to.
Thanks, Sally. Do you want to use this? No, I'll use this. Let's stay seated. Thank you. Oops. All right. So, hi, everyone. Our next study is a vaccine-based study in the ED. So there were a handful of ED-based vaccine program studies that we looked at from 2022. We chose this one because of the study design. It's a randomized controlled trial, which we know doesn't come around all the time. It's published in JAMA Internal Medicine, and it was a collaboration across 4 different academic institutions in 4 different cities. So Jeff in Philly, Duke, and then University of Washington and UCSF. So the question that this collaboration of researchers asked asked was, does provision of a COVID-19 vaccine educational messaging platform to patients in the emergency department actually increase their acceptance and then their actual uptake of actually getting the COVID vaccine in unvaccinated ED patients? So this was a study of waiting room messaging. So these patients were all kind of a captive audience to assess the acceptability and uptake. It was a cluster randomized trial. It was in 7 different EDs, and it took place in December of 2021 to July of 2022. Their target population was those who primarily received their primary health care in the emergency department, so without PCPs. They enrolled non-critically ill, unvaccinated patients who were in the waiting room. And the interventions in this study were a combination of either a 4-minute video in English or Spanish to message about the vaccine, a 1-page flyer, or a brief scripted verbal message from either the ED physician or ED nurse. They enrolled 496 patients. The median age was 39. They were about 40% female. 39% identified as African American, whereas 19.6% identified their race as Latinx, and 44% of the patients did not report having a primary care doctor. So here's just a still image of one of the videos that they showed. And they studied vaccine acceptance by a survey that patients took right after receiving the message of whether they would accept the vaccine. And then they actually looked at whether the patients received a COVID-19 vaccine in the registry within 30 days of the intervention. And in brief, kind of what they found is that after the intervention, more patients found that they would accept the vaccine and actually did get the vaccine. So with a very low number needed to treat, the intervention actually improved acceptance on a survey and uptake. This effect size was higher in patients without a primary care doctor and in Latinx patients. So just in the essence of time, I'm going to stop there and turn it back over.
Okay. Thank you. Okay, so this paper looks at disparities in emergency department prioritization and rooming of patients with similar triage acuity scores. So we all know that triage is a combination of objective and subjective measures. The subjective measures are prone to bias, error. The goal with triaging patients is to prioritize the sickest patients who need the most resources. In the United States, 70% of emergency departments use the ESI scale or the emergency severity scale, index scale. And when it comes to thinking about who we prioritize when patients have the same or similar ESI score, there's something called the first come, first serve policy that, basically says the people who came first with the similar ESI score should be seen first by a provider. And so the definition of an FCFS, first come, first serve policy violation in this study, so what they said was that patients who are prioritized in violation of FCFS were prioritized if they were roomed 15 minutes before a patient who arrived in the waiting room before them. A patient was said to be deprioritized if they were roomed after a prioritized patient, despite entering the waiting room before the prioritized patient. They used the margin of 15 minutes, and that was deemed a violation of FCFS. So their question here was, they wanted to determine patient characteristics and ED operational conditions that were associated with prioritization and rooming decisions for patients who were triaged in a similar ESI score. So this was a retrospective analysis of all ED visits at a Southeast U.S. academic health center, January to December of 2019. This hospital saw approximately 60,000 annual ED visits and has 59 total beds in 5 different areas. All of the triage nurses are dedicated and have dedicated training in the ESI scale. So for this study, they included patients who had an ESI score of 3, And they had to be evaluated in 2 specific areas that operated similar 24/7 hours and had similar provider and staffing nursing ratios. And also, all of the patients in this study had all of the event timestamps marked in the EHR. They excluded pediatric patients, and they also excluded patients who were brought in by ambulance because it was a different workflow, and also for patients who might have had a mental health-related chief complaint because they had a different workflow as well. So they used 2 models. Both of them are logistic regression models. One is a weighted model where basically they're trying to figure out what patient characteristics and ED conditions might relate to whether a patient is prioritized in violation of FCFS. So they looked at things like age, sex, race, ethnicity, but they also looked at the day of the week, the time the patient came into the emergency department. And then they did another logistic regression model that basically focused more on the patients, took one patient who was prioritized and compared them directly to a number of deprioritized patients who were waiting in the waiting room at the same time. So this was a matched case control logistic regression model. In this study sample, they had almost 16,000 unique ED visits. The mean age was 48 years old. And they were about 58% female, 29% African American. And the 2 most common chief complaints were cardiovascular and GI categories. Overall, 10% of ED encounters were prioritized in violation of FCFS. So both models, logistic regression models, showed similar results. In general, older patients were more likely prioritized than younger patients. The prioritization was low, likelihood was lower for African Americans when compared to Caucasians. And there were also certain chief complaints that were associated with increased odds of prioritization. And as I said before, the other logistic regression model showed similar results. They also did a second sensitivity analysis looking at, rather than 15-minute margins, 10-minute margins, and 20-minute margins, and they found similar results. So this just highlights the findings again, and here again. The take-home here is that age and race is statistically associated with prioritization in rooming decisions among patients who have ESI score of 3. And this is problematic as EDs are becoming more and more overcrowded, as the rate of FCFS violations may actually increase. Thank you.
Thanks, everybody.
Awesome.
That's
Yeah,
our top
thank you so
5
much.
this year.
We're actually out of time, but if anybody wants to ask questions, we're here, and I don't think the room has been being used, so. Yeah.
Thanks so much. Those are
Yeah.
pretty good papers you guys picked. For the one on boarding times and race, did they give an average waiting time difference between African American and Caucasian boarding times?
Yes, they did. You can look at the paper for the exact times, but for African Americans, it was about 4.7 hours, and for Caucasians, it was 2.6 hours. Yeah.
Yes.
Hi, thanks for this interesting talk.
Of course.
One more question. About the boarding time and pediatric specifications and different than others, did you notice difference in the reaction of the patient itself, like the patient perspective, of prioritizing them and not prioritizing them?
For the first come, first serve study.
I think the question is, did they look at all at the patient dissatisfaction from the wait times?
Yeah, unfortunately, in this paper, they didn't look at satisfaction specifically.
That'd be an interesting follow-up study for
That
sure.
would be.
Yeah. Yeah.
I also forgot to mention in my paper, sometimes the difference between jail and prison isn't exactly very clear. And just to clarify a little bit, jail is where you're taken when you're arrested for any small petty crime. It doesn't necessarily mean that you've been charged. So you can hang out in jail for a while and be innocent, as in you haven't had a trial and you haven't been charged. Also, while you're waiting for trial, if you can't make bail, you're in jail. So Although they didn't look at it in the paper, they did mention that it's very possible that many of the crimes that these people were arrested for and taken to jail were like public indecency because they were urinating on the side of the road, or petty crimes like, picking up small things from a convenience store, loitering, things like that. So that's where the idea of like creating structural change, so that as their social needs increase and they're visiting the ED more for that, we would be able to address those needs and maybe prevent the jail encounter. I apologize if that wasn't clear.
Well, thanks, everybody.
Yeah,
We'll be
thank
here
you so
for
much.
2 minutes, and so if anyone else has any questions, you're welcome to come up.
Also, sorry for the echo. I don't know why. Just like this huge room. I know. Yeah. People didn't know to book their flights after our talk.